So this session is going to be on Hallux Valgus, MIS versus open. Laurent Goubau is a orthopedic surgeon from Europe, and he's going to moderate this session for us. It's all yours. Nope.
Okay, thank you.
Hey guys, oh, hold on, I'm going to have to do that again in a minute. We're on standby. All right, welcome everybody. We are almost at the 1/3 mark for our 24-hour marathon. This session is going to be on Hallux Valgus, MIS versus open. From Europe, Laurent Goubau, Dr. Laurent is going to be moderating the session for us. I want to thank Osseo for their sponsorship of this session. It's all yours, Laurent.
Okay, thank you, Selene, for this introduction. So welcome to the Parekh Foot and Ankle Global Townhall session about Hallux Valgus surgery treatment dilemma. So should we go minimal or should we go maximal invasive surgery? I am Laurent Goubau, foot and ankle surgeon from Brussels, and I will be the moderator for this session. I would first of all thank Selene for inviting me to be a moderator, and I'm thankful for the traveling fellowship I did with him in 2017. I would like to thank also the foundation and of course the sponsors to make this happen, and I apologize already for my technical issue in the background. So let me introduce Eduard Rabat, who is a foot and ankle surgeon from Barcelona. I did a fellowship with him in 2016. He will talk about MIS scarf with screws. And then we will hear Adrien from Geneva, Switzerland, who will talk about a MIS technique with K-wire. If there's time, I will talk about a case with DMNA correction. Dr. Anthony Sakellariou from the southwest region around London will share a case about lapidus correction. I was also a fellow with him. Dr. Devos Bevernage, who is my colleague at the Foot and Ankle Institute, will talk about the scarf without screws. He has a lot of experience in that field. He learned me almost everything about foot and ankle surgery. So I think we can head up to listen to Eduard Rabat and the percutaneous scarf with screws. So Eduard, the virtual floor is yours. I will stop sharing my screen.
Okay.
So you can share your screen.
Hello, everybody. First of all, thanks, Selene and also Laurent for this kind invitation and for this great meeting. Minimal or maximal invasive surgery, for us, there is only good or bad surgery. In Hallux Valgus surgery, our choice has been always mainly the scarf osteotomy that, as you know, was introduced in Europe by the Baruch family. We have adapted the scarf to MIS, and this in primary surgery, our choice is in the 95% of the cases, the percutaneous scarf. But in rescue or second look surgery, it's the inverse. It's 90%, it's open surgery, and we use a scarf, whale of the first ray or arthrodesis. And like in this case, that's an open scarf. For us, the percutaneous scarf advantages are that it's a gold standard technique that we know perfectly well and associated with a minimal invasive surgery procedure. And this is as how we do the
incision is performed medially between the dorsal and the plantar skin and should be half a centimeter long, a bit long than usual, and always behind the bony prominence, exostosis. Next, we detach the bursa and create a virtual working space. The exostectomy should be minimal, just enough to give a round shape to the first metatarsal head. There is always time for more if needed at the end. It is important to locate the apex of the osteotomy at the center of the first metatarsal head. The direction of the bar will determine the shortening effect on the frontal plane. If the inclination of the osteotomy is perpendicular to the second metatarsal bone, we then shorten the first ray by approximately 3 millimeters, 2 millimeters due to the Shannon bar and 1 millimeter due to its vibration. If we prefer to shorten even more the first ray, because the deformity so requires it, we then tilt the bar towards the proximal direction, thus achieving a shortening effect of up to 1 centimeter. If we prefer not to shorten the first ray, we then need to tilt the bar distally to compensate for the shortening. Next, we perform the distal osteotomy from the apex to the dorsal cortical. See how the thumb controls the exit of the bar. In this demonstration, we are using a Shannon bar of 20 millimeters. Then we execute the longitudinal osteotomy, which should run parallel to the main axis to the main axis of the first metatarsal. Watch how the hand moves by at least 1 centimeter proximally. At this point, we have created another apex, the proximal one, from which we will create a plantar osteotomy. Once the 3 cuts are completed, the 2 fragments are mobile, allowing us to check the correction capacity. Here we can see the third osteotomy, the third cut from the proximal apex to the plantar cortex. And now we will see from another side. We can see from the proximal apex to the plantar cortex. And at that point, the 3 cuts are completed and the 2 fragments are mobile, and we can check the correction capacity of this osteotomy. To keep the desired correction, we will introduce a 2 millimeters key wire through the same incision to push the metatarsal head laterally and dorsally, while at the same time keeping the desired correction. The key wire will cross temporarily the first tarsometatarsal joint. Now, the proximal osteotomy is stable and we are able to rotate the metatarsal head. Abduction of the toe is desired to tie the toe and the key wire together with a gauze. At that point, we have stabilized the osteotomy and we are able to make the osteosynthesis. Here we can see how we are attaching the big toe to the key wire with a gauze. And at that moment, we achieve a good stabilization of the rotation and also the TMMA angle of the osteotomy. To stabilize the osteotomy, we will introduce a 0.9 key wire, at least 1 centimeter proximally to the more proximal osteotomy, from dorsal to plantar, directed to the most plantar point of the metatarsal head. Here you can see how we introduce a 3.0 diameter self-drilling, self-taping screw. Once the screw has crossed the dorsal shaft, we can remove the 2.0 key wire millimeters while we continue to introducing the screw. This step is done simultaneously. At this stage, we have achieved compression of the osteotomy, as we can check with the mini C-arm. Note that from all the steps performed, the only soft tissue procedure that we are going to do is the abductor tendon tenotomy release through this lateral incision with this movement that we can control with the mini C-arm. In most of the cases, approximately 90% of them, we perform an aching osteotomy, which we never osteosynthesize because we do by osteoclasia. It is possible to use osteosynthesis.
Well, here some cases, some clinical cases. Is that one with DMMA osteotomies of the lesser toes. This is another case. Another one. In many cases, we are using 2 screws if you feel more confident. The first one is, as I show you, from dorsal to plantar, and the second one from medial to lateral. What is remarkable in this technique is, given that we don't damage the joint, we obtain a very good active and passive range of motion of the first metatarsal joint, especially the dorsiflexion. The dorsiflexion, it's very remarkable, the good result that we obtain here. This is another case, clinical aspect, the range of motion. This I think it's one of the advantages of MIS in this case is that we don't touch the joint. Our indications is in hallux valgus less than 20 degrees of intermetatarsal angle. And conducted by Josep Torrent, we have done a study, open versus minimally invasive scarf osteotomy for hallux valgus correction, a randomized controlled trial. This has been submitted to Foot and Ankle International, approved, and it will be published very soon. And the conclusion of this work was that the MI scarf provides a clinically and radiologically equivalent outcome to open scarf for treatment of hallux valgus with reduced surgical time and immediate post-operative MIS for pain. The difference seen in radiation exposure is insignificant in relative terms when compared to other common orthopedic procedures. And that's all. Thank you very much.
Thank you, Eduard, for this very nice talk. We have 3 minutes left for questions. I have one question. Do you feel it's necessary to do a lateral release in most of cases, or do you feel that in most cases the lateral release is not needed? And if it's needed, how do you perform it in a way to avoid any difficulties?
Well, I think that here it's a difference with MICA procedure, no? Because I see that in MICA, the pushing, the lateral displacement, it's brutal sometimes, and then a lateral release may be dangerous because you can have an hallux valgus. But in a normal scarf osteotomy, I always do abductor tendon tenotomy and lateral capsular release. Especially if you are going to do an aching osteotomy, that we do nearly always, because when you do an aching osteotomy, I think it's necessary to do an abductor tendon tenotomy, because then you can change the position of the big toe altogether. No, if you don't release, maybe the lower part of the osteotomy will remain in the lateral side, and you can have a non-desired displacement. I don't know if I answer the question.
Absolutely. Thank you. I don't know if we have time for another question, maybe from the panelists, if someone has a question for Eduard.
Eduard, thank you for your presentation. How do you avoid the troughing effect? We saw that in that video that at the end you see a little compression when happening. Do you also do that in osteoporotic bone, your percutaneous surgery? Is this a contraindication?
Normally, we don't see trophic effect. In osteoporotic patients, that is a big discussion. Sometimes we have seen ruptures of the distal edge of the osteotomy. And normally you see that the osteotomy has not been perfectly stable, but also I have to tell you that the final result is not bad in elderly people. But I think you can do also in osteoporotic bone.
Okay, thank you. I think we can move on to the presentation of Adrien, since we are running a little late. but we will be able to ask other questions relating to MIS after the presentation of Adrien. So Adrien, the virtual floor is yours.
Yeah, thank you, Laurent. Thank you for the invitation for this great meeting as well. Just going to share everything. So I will present you today my technique for the percutaneous scarf. I've been through different type of osteotomies, MIS osteotomies. I started with the technique I will show you today, which is this technique. I've done this for the last 10 years. 9 years ago, I went to Barcelona for my fellowship and learned with Eduard this great technique. I still use a lot in different cases. And as a MIS surgeon, I also tried, of course, different techniques, the different trends. I tried the Mika technique, which is very powerful. I'm not personally very comfortable with this technique. I think it's extremely demanding, and I actually stay with my first love, and this is what I'm going to show you today. So this technique is pretty simple. You use 3 percutaneous protocols for that. The first one, of course, is for the metatarsal osteotomy. The second one will be for the K-wire insertion. I usually use a 2.0 K-wire. And the third one would be for an Akin if you need to do one. I also have a lateral portal for the lateral release if needed as well. Now for the landmarks, it's pretty obvious and simple. I'm trying to find with my thumb the neck of the first metatarsal, which is exactly where it's supposed to be. On a closer view, I start my osteotomy on the dorsal part of the metatarsal, because with MIS sometimes you don't do exactly the cut you want. So by starting a bit higher, you avoid having a short plantar cut. So I prefer to start a bit higher and then be a bit oblique with the central cut. Now, from the dorsal view, the red point will be the entry point for this osteotomy. You see, it's a bit more proximal than a regular scarf or chevron osteotomy. That would be the blue point. We can do this with the percutaneous surgery. I noticed that we have less troughing with the microinvasive surgery. And by going a little bit more proximal, you are extra-articular. So it's much easier to reduce, to translate, and to reduce the sesamoid bones. I'm not going to show you how to do the ostomy because it's exactly the same as what Eduard showed us. So when the osteotomy is done, I make a small keyhole at the level of P1, put my K-wire in. Usually I just push my K-wire against the head and I put the K-wire in the shaft. I don't use a power tool for that. I just push it with my hand and impact the K-wire in the CMT joint. And here you see I just did an Akin and I don't fix it neither. So this would be the position of the K-wire. This is the patient standing. So you see the K-wire is pushing against the head of the first metatarsal. In the dorsal view, you see that the osteotomy is stabilized medially by the K-wire and dorsally by the osteotomy itself. This would be a regular case, simple Hallux Valgus, correction, reduction of the sesamoid bones, actually reduction of the head on the sesamoid bone and the small Akin. And this is the position on the lateral view. This is a very important position if you want to try this technique. Actually, I learned this with really some terrible results. So this is what I'm going to show you here. If you visualize the center of the head of M1, which would be the red point, your K-wire needs to be plantar. If you put your K-wire in this position, the K-wire will act as a compressing force on the osteotomy. If for some reason, and it happens to me many times at the beginning, you're not really careful when you put your K-wire over the head or over the center, it would slide on the head and push your metatarsal bone downward. And this will probably lead to dislocation of the osteotomy and a shortening of M1. And all the problem you all know when you have a shortening of the first metatarsal bone. So be careful, put your K-wire under the center of the metatarsal head. So this is our case. 3 months later, 9 months later, I keep the position, it's fine. Another case here to show you that you can make larger displacements. So you see here we have almost, let's say 90% of displacement with some DMMO as well. The correction stays and it's pretty easy to do this type of displacement with a K-wire, and it's much easier, I think, to do this with an open scarf with screws, for example. Another case here to show you the position of the sesamoid bone. I've been asked many times if we can reduce the sesamoid bone if we don't touch the medial capsule. It's a very interesting question. I think that if you reduce well, you de-rotate the head and you bring it back on the sesamoid bone, you can reduce the sesamoid bone most of the time. In this case, for example, you see the reduction, which I think is okay, and the result. Another case here, you see sesamoid bone. This is the position after surgery. So don't be afraid if we looks like we are in varus, just the bandage that brings the toe in this position. Now, Laurent will speak about this later on, but I think it's an interesting technique in case of an abnormal DMAA. You see here the articular angle, which is abnormal. So depending on the technique you use, it can make the thing more complicated. If you do a Lapidus procedure, for example, it's quite hard because it can worsen the situation. If you don't open a scarf for chevron, you probably have to do a second osteotomy to correct this. But with this scarf, it's pretty easy. Since your K-wire is following the plantar fragment, the position of your K-wire will decide what's the position of the head. So if you turn the K-wire, you will turn the head as well. So in a regular case, you see the K-wire is aiming the medial part of the CMT joint. If I turn my K-wire and I aim the lateral side of the CMT joint, impact it in the lateral side, I will rotate the head and correct the DMAA. So it's something I do during surgery, put my K-wire in, check the DMAA and turn the head as needed and impact in the good position. So in this case, for example, you see you can just rotate the head, bring it back to normal, don't have issues with the recurrency of Hallux Valgus because you didn't correct the DMAA. Now, last case, big question. We had a nice talk with our colleagues earlier to say when to do, when not to do MIS. I think that MIS is a tool and you need to use it with other techniques. If you're not comfortable with the foot and MIS, don't do it. It's not good for the patient. So this case, for example, the right side is fine. It's like Hallux Valgus, and I corrected it with this technique. The left side for me is too big, so why trying to do something and have bad results? So in this case, I did a regular open scarf. This is a Maestro scarf without screws, and I'm much more comfortable for large cases like this, and this is the result. So the indication is an MIA less than 18 degrees. Over this, I tend to use an open surgery. And I think one of the good thing in this technique is that since your K-wire is pushing against the head, you don't need to have a screw, and you don't really care about the bone quality because it's not supposed to hold into something. So even if you have an osteoporotic bone, you have good result with this technique. Post-op, nothing special. I just removed the K-wire after 5 weeks in my office, and that's it. Thank you very much.
Great, thank you. Very nice talk and pictures and illustrations. I have a question for you. What is in an equivalent Hallux Valgus surgery indication for you the main advantages of the minimal invasive technique, and why would you recommend it to? I would say.
Sorry, Laurent. No, if you ask, I can't hear you.
Do you hear me? Hello. Do you hear me? Yes. Okay. Adrien, do you hear me? No. Can the other panelists hear me?
Yeah.
Okay.
Yes, we can hear you.
I think we lost Adrien. Maybe,
well, bad disconnection. Sorry, I'm back.
Okay, no problem. So my question was, what is in an equivalent Hallux Valgus deformity indicated for surgery? What are for you the main advantages of using the minimal invasive technique?
Well, I think if you're comfortable with it, I think it's faster for you. And for me, for example, this DMA is much more comfortable reducing it with this technique. And some patient, of course, the patient want to have the last technique, or they don't want to have a scar. I tell them that it is not what is important. I've learned to do this, and I think I'm very comfortable with it. Now, for my patient, honestly, I don't think there is a huge difference. I expect maybe the only difference I see is that they gain a bit faster their mobility. For the rest, yes, a bone heals in 6 weeks. Same for the ligaments. If you did open or percutaneous, it's the same. So we hear lots of things, marketing things about the result. And I don't really agree. The results are almost the same. It's just sometimes more comfortable, and you have to know why it helps. And for me, it helps for DMA in young patients, for example.
Hey, Laurent, I have a question from the attendees. They want to know, how much X-ray do you use doing MIS and percutaneous, and how do you manage the amount of radiation exposure versus open technique?
So actually, this is one of the reasons I switched from the screw technique to this one, because with this one, I have to scope 3 times. When I put the KY, when I do the osteotomy and the final result. With the screw, you need to scope a bit more. And this is a concern, of course, MIS and radiation. So you need to be very careful. And if you're comfortable with it, you don't need to scope a lot, actually. I don't know about you, Eduard, but I guess it's the same.
Yes, in the work that we have done, we have controlled the dose of radiation, and of course it's bigger than in an open scarf. Anyway, we use a mini C-arm, and the radiation that we receive is not more than in an other orthopedic procedure, no. But of course, it's a concern, no. Anyway, the mini C-arm, the only radiation is in a very reduced area. But it's a concern, of course.
Okay, maybe one last question for MIS, and then we'll go over to a DMA case. I don't know if Anthony, you have maybe a question for the MIS techniques.
He has to open the micro.
I don't have any questions, because I think Adrien and Eduard presented those cases in a very balanced way with all the pros and cons.
Great, thank you. So I would like to share a case of a DMA correction with you. So, this is a young lady with a little DMA augmentation. She is 18, 16 degrees of intermetatarsal angle, 25 degrees of Hallux Valgus angle. This is the 90-degree angle, and this is the estimated distal metatarsal articular angle, which is 15 degrees, but it could be 20 degrees. It's a bit difficult to assess properly on X-rays. And this is the sagittal view. This is the osteotomy that was performed. So bunionectomy is performed and used as a tool to block the osteotomy. The idea is to make a distal cut, which is 60 degrees regarding to the axis, so we can lengthen and then shorten the distal part of the osteotomy, so that we end up in a same length after fixation. So we see in this case that at the proximal part of the osteotomy, the translation is more than at the distal part, which allows us a theoretical derotation of the DMA. This is the angles that we can that I measured, and we come up with a reduction of 15 degrees. Hallux Valgus is 4 degrees. This is the sagittal view, and here we are 3 months down the road with the same length of the metatarsal, with the DMA corrected. And this is the sagittal view, and this is the clinical view at 3 months. So I just wanted to share this case to introduce the topic of DMA, of course, and to know a bit your opinions. We have 5 minutes to discuss about that. Main question, several questions. Do you prefer translation above rotation? And what is your opinion regarding to osteochondral lesions because we have unpublished data showing that in 60% we have osteoarthritic joint, and in 40% there is an osteochondral lesion associated. So how do you deal with the variables DMA angle and osteochondral lesion? So maybe we can have a chat, and maybe if everyone could give his advice, it would be interesting to hear. So maybe, Eduard, you can start.
Well, but I think that given that it's always shortening, this is good for the osteochondral lesions. And I think that it's a balance in between translations and translation, the rotation and the MMA correction, no? Because that's the reason why I like very much the scarf, because you can play in all the deformities, no?
Okay.
Laurent, I didn't quite understand. Do you say that all cases with a DMA deformity had some arthritis or an osteochondral lesion? Is that what you said, or many of them?
No, I'm just saying that we have data about osteochondral lesions associated, but I think
associated with what?
With Hallux Valgus deformity, so, but knowing that with the DMA correction, it could give different. You need to choose between translation or rotation, and I just want to know if you have this in mind, osteochondral lesion or not, if that changes your attitude to translate or more to derotate, or doesn't matter.
I think the two will vary, because with an osteochondral lesion, you probably need a rotational correction, because then that will change the pressures, the joint pressure on the osteochondral lesion. So if you're going to get a better result, theoretically, the rotational correction will be better for an osteochondral lesion. For a slightly arthritic joint, it's the decompression that probably makes the difference. So a translational with an osteotomy, which means you lose about 1 millimeter or 2, decompresses the joint, and therefore probably lessens the likelihood of any persisting stiffness or anything like that. So I think you probably need to choose between the two. My personal choice for DMAA correction is a biplanar scarf, a biplanar chevron. So, and very occasionally I do a rotational scarf, but I really like the biplanar chevron for DMAA correction, especially if it's quite a big one.
Okay, thank you.
Because with a scarf, if you need some rotation, the fact that you have to, and there's a big IMA, you lose your IMA correction with some of the rotation, because you lose some of the contact for later fixation. So for big DMAAs, I prefer the biplanar chevron. For smaller DMAAs, then the scarf is fine.
Sorry, Laurent, may I say something? In the percutaneous scarf, as we do, when we have introduced the key wire, and we have the proximal part of the osteotomy fixed, and then it's very easy to rotate, because we have a space that the bar has created, and then you can move the big toe and the distal part of the osteotomy. I think it's more easy to control the rotation with the percutaneous scarf than with the open scarf. It's my opinion.
Okay, Bernhard.
I do think you need to take into account both of them, as well as the DMA, as the shortening the osteochondral lesions. I don't think your technique may be the limiting factor to choose for the DMA or for the translation. I think you need to address both. But what we've seen quite often in our team, you know it, is that there's some osteochondral lesion, and maybe you're talking about that, in between the sesamoids and the metatarsal head. If you have a long-standing rotational thing and then you want to reduce them, sometimes the lateral sesamoid kind of created a hollowness in the lateral part of your head. And then if you reposition the metatarsal head onto the sesamoid, sometimes the sesamoid point has a tendency to dislocate again in that chondral lesion or impaction that you had on the head by the long-standing Hallux Valgus. And so that's what we have seen, that is one of the contributing factors to recurrence, is that chondral impaction on the plantar lateral aspect of the metatarsal head. But there's unfortunately not so much we can do about that. But in our team, we always say you choose for the translation more than over the DMA if you have a very large translation to do.
Okay, thank you.
There's another question. Can a long scarf be done with MIS technique?
Oh, yes, absolutely. I do often, maybe I show you one case at the end. You can do a scarf, a normal scarf, almost up to the proximal part of the first metatarsal. It seems strange when you think that you're doing everything through a small keyhole, but the skin is elastic. So you can easily, if you don't have the cutting part of the burr on the skin, you can easily push the skin and make a scarf as long as you want.
Thank you.
And that doesn't burn the skin.
No, it doesn't. You need to open a little more if you want to do a long one. Unfortunately, this is the type of thing you learn by mistakes, but actually, if you open a little bit more, 1 millimeter more, you can go up to the proximal part without any issue.
I normally open more or less 1 centimeter, and it's enough. And the movement of the hand, to have to approach the hand to the skin, your hand, the surgeon is.
Yeah, it's a rotational osteotomy. You have to rotate the hand, not translate the hand. This is the key.
Okay, thank you. I think we're running just on schedule. So if Anthony could share his case, I'll stop sharing my screen. So we're happy to.
I haven't been given control of my screen yet. Oh.
Yeah.
Okay, hang on. Share screen. Can you see that?
No.
Not for the moment. Did you do share screen?
I did.
Okay. And did you
But
go to...
my screen isn't up yet. So I can't see my own.
Yeah, we can't see it yet. Chris, do you mind helping out here?
I can start while you try. I don't mind.
That sounds okay.
Because I can see myself on the top, but I can't see. I'm not on the main screen yet.
So if you hit on the bottom, can you hit share screen?
Sure, but I get a panel that says desktop, iPhone, Safari, desktop.
Yep, just pick which one you have.
Share.
If you want, I can share my screen. I have your case.
Maybe you can pull it up, Laurent.
Yeah, okay.
And then Anthony will just tell you to.
The trouble is I can't see myself on the screen except on the top. So I can't share I can press the share button, but nothing shares. Now I see Laurent.
Shares it. Would that work for you? And then you could see it on the screen.
Hang on. This is a bit. Do you see my screen?
I can see. We can see your screen. Yeah.
Okay. I go to.
The thing is, it won't be you who's. It won't be me who's advancing it.
Yeah, I know. No.
And at what pace? This is really strange because I can see myself on the top left in the thumbnail screens, but unlike before.
I will do, if you like, I can change the images when you tell me to do.
Sure.
Okay, go ahead.
Go.
Laurent, we can't see the presentation anymore.
Okay.
Maybe I'll go on and share my screen. Or...
You see, I can see Bernhard now, but I can't seem to. I can't seem to get myself on the main screen.
Do this, Bernhard. If you want to share your screen, and I'll, in the meantime, ask the guys to help Anthony out.
I'll start out. You see?
Yeah.
Okay.
That's fine.
Okay. I think the discussion about minimal or maximal invasive surgery is more about concept. I think you need to go back to the concept of a reconstruction of the first ray, which will be to obtain a functional ray, correctly angulate in all the planes and mobile if possible, and always in perfect harmony with the lesser rays without leading to some transfer metatarsalgia. And the surgery of choice is difficult. There are more than 130 techniques out there. And I think the most important thing is that the surgeon needs to be comfortable with the chosen technique. The problem is also, if you are in a team like we are with fellows coming over, that it's the technique that we are going to show needs to be a reproducible one, a reliable one, and by preference, a stable one. And that's a little bit my concern with the MIS, that it's not always so reproducible in the hands of people that are starting with it. So the purpose is to avoid by all any iatrogenic lesions. And then I think a good surgeon for open surgery, it's easier to learn to the fellows coming by. So this choice of the surgery will depend on the severity of the deformity. For me, especially the reducibility of the MTP1 joint, and more of that, the mobility of that joint once it is reduced. And then even, we talked about the DMAA, the stability of the CM1 joint was not addressed, but I think Anthony will talk about that. And then the length of the first metatarsal compared to the other ones. And then your choice at the end, if it's MIS or open surgery, will be, is it a conservative surgery? You're going to maintain a mobility, or are you going over to an arthrodesis? But the purpose of all of it is to reposition the head onto the sesamoids. And by preference, if you want to have a nice mobility and a happy patient, few or no tension on the soft tissues. All that by a multi-directional adjustment. And for me, that's a scarf osteotomy. You see a little example in the time we're still using screws. And the advantages of that scarf osteotomy is allowing a deformity correction in all the planes. You have the lateral translation, you have the sharpening if you need it, you can lower it, and you have rotation in all planes. And what is the advantage of the technique I'm going to show you is a lot of people, we are talking about the rotation for the DMA, but there's also the rotation of the head of the diaphysis happening in between the midfoot and the toe. And by the fact of not using screws, like I'm going to show you, was published in 2012, but I was trained with it. And I was trained in 2004 already with it. It's a scarf without any screw. You have low cost, no material. Companies do not like us for that. But the advantage is no hardware removal. And you're capable of doing a much larger translation, because very often the thickness of your screw, the material will prohibit you a very large translation. And you also have, if you have a large translation, risk of fractures when you put that screw. And an osteocentesis, like we all know, does not replace the quality of your osteotomy. You need to do a good osteotomy, stable and reproducible. So the modification of this technique to the original technique is that Laurent showed it already a little bit. We do an oblique osteotomy, and by translating laterally, we kind of lengthen the metatarsal, and then we take out that little bump in the head, and then we kind of enclave it again one onto the other, and you have a stable osteotomy from the beginning. But you can argue that the proximal part will not be so stable, but then you just flip over the resection of the medial side of the proximal fragment, and you also stabilize the proximal part of it. So you can do translation, everything you want with that. So this is an example. You see it's a quite large translation with a big DMAA. And here we were able, just by doing that scarf osteotomy, to address all the problems with a nice repositioning and a parallelism between the MTP1 joint and the IP joint. The advantage is that if you have no stress bridging, you have a callus that is more adaptive, and remodeling that is even of a better quality. The disadvantages is that you need a perfect understanding and surgical control of your technique, and you need a soft quality. If your saw is vibrating too much, your cut will be too thick, and you will end up with a problem and less stability. But don't forget that you can always still put in a screw or a plate, or especially an osteoporotic bone, an extreme translation and the correction of DMA. We therefore developed this scarf extreme plate some years ago, and here you see an example. If you looked at that intermetatarsal angle, you also see she already had surgery on the 5th toe for some infection over there. It's a young lady in the 20s, and if you looked at that, you see like a hypoplasia of the sesamoids. And I started to do my translation, and the purpose was to correct the DMA. And you see in the middle here of the distal part that we already were taken out a piece of bone, and the purpose was that part, I don't know, see if the arrow, but the purpose of that was to be enclaved again in this part and being stable by that. But during surgery, we saw that the DMA was so much exaggerated that we even needed to translate the entire distal part. So there's no overlap at all in between those fragments. And if you look to this X-ray, only 6 to 8 months after surgery, it was stable with a nice remodeling over the time that was come. For the pain on the 5th, we just did an arthroplasty. But there was no loss of length, and she didn't have any metatarsal, but you see the remodeling that is possible with the scarf osteotomy. So maybe you can obtain it by MIS, but I had everything under control, being visual during surgery. This is a more straightforward case. On one side, you see a little bit more MA angle than on the other hand. But if you do a nice translation opening, stable from itself, you end up with a correction that is good in all planes. And by the fact that you don't put any screw, at the moment of you putting both fragments together again and doing a mobility dorsiflexion of the toe upon the metatarsal, you sometimes see that head turn a little bit. And I can agree with people that are talking now from proximal osteotomies with the rotation, that it brings back the head to the sesamoid, but that it's all happening spontaneously with this scarf without screws. So I have a case discussion on this female. She's only 14 years old. She has pain for years. She is not helped by sugar modification or orthotics. It's like 14 years old. It's a juvenile bilateral Hallux Valgus with no metatarsalgia. You have some difficulties to reduce that first MTP1 joint and a loss of mobility in that partial reduced position. She has some discomfort between the sesamoids and the metatarsal head, and some generalized laxity also at the TMT1. And she comes to you and she wants a final solution. She has been sent home by colleagues for years, but she wants a solution. And this is what you see. You see that IM angle that is quite increased. You see a metatarsal head. You see a whole dysmorphism of that metatarsal head, and probably a lot of dysmorphism in between the sesamoids and the metatarsal head. I have not operated her, but I can show you a next case that I have operated some years ago. It's a Marfan, and in the Marfan, you also see some big deformities, pretty much like this. So I don't know if the panel has some ideas about this case. What would you do? You do a scarf, you do something proximal, you do a double osteotomy. What are your ideas? You can address this by MIS, or you need open.
Well, I wanted to ask you this. I think this is the most difficult cases in Hallux Valgus, because you have this usually hyperlaxity, and you maybe want to do a lapidus, and the lapidus will worsen the situation. And in these cases, sometimes I had to do a lapidus for a hyperlax patient and then a distal osteotomy to correct the DMA. I don't know if someone can do everything in one step, but I don't think it's possible.
So if you look to the lateral view, you don't see so much opening on the plantar aspect of the TMT1 joint. So if you go to that young lady of 14 years old, you do your proximal arthrodesis of the TMT1 joint, and you do a distal rotational osteotomy to address the DMA. Can you assure that lady who you're going to fix at the midfoot that she won't have any pain between the head of the metatarsal bone and the sesamoids? Meaning, if you end up with a lady with a TMT1 joint fusion, and you also have that arthritic changes, and also already at that young age in between the head and the sesamoids, my only solution for problem in between the carpet and the sesamoids is to do a fusion of that MTP1 joint. So if this is this a good solution for you? Already fuse at the midfoot and knowing that in a few years you probably end up with a fusion of the MTP1 joint, or you're going to do a proximal osteotomy instead of a fusion of that joint.
Well, I think at this age, you're not supposed to have any arthritic change in the sesamoid bone. The thing is that you want to go with a scarf here to correct the DMA, and you can definitely do this. The question is, will it be enough to stabilize the first ray? Because yeah, you showed us that maybe there is no instability. In this case, I think a scarf would be the perfect solution. The big question is if you have this and a hyperlax patient, for example, your Marfan patient.
I don't say she has already arthritic changes, but she has that dysmorphism in that foot, in that joint, that probably will lead, even if you put it back onto the sesamoids, she didn't grow like that. So she can, in the years to come, more easily develop some arthritic changes there. And then you end up with a fusion in the mid and I'm not saying you need to do a scarf ostomy. Maybe I shared the case that I operated this Marfan. It's a little bit the same. So we did that things years ago. I haven't seen her back. This is an X-ray almost at 1 year, I think. She was stable. She was happy with that surgery. But I do not know at all what is going to happen in between that head and the sesamoids. This is one of the questions I want to put out there today. Showing the scarf is a marvelous osteotomy. It's stable, it's reproducible. There are other ways to do it than just put a screw or 2 screws or no screw or even a plate. We may not be stubborn with our technique, but it needs to be modifiable. And maybe we need to think sometimes out of the box, like in these cases. Thank you.
Okay. Thank you very much. Very nice case. We don't have a lot of time. I think we have 6 minutes left before we end. Anthony, do you think we can see your case? I don't know if Anthony can hear us.
Yeah, I don't even see him on the. If you guys.
And maybe we can
questions.
Continue about the case of Bernhard.
Yes.
I don't know if there are any questions for the case of Bernhard.
So Bernhard, you know, in the US, one of the thoughts in that kind of case with hyperlaxity would just be to do a first MTP fusion versus even doing a lapidus. What are your thoughts on that kind of situation? Just do an MTP fusion and be done.
In which case, the last one, the young lady?
Yeah, with the Marfans.
I think that's what I told during the talk, that we cannot limit ourselves to one technique. Maybe we need to combine some techniques. I understand that lapidus is a very powerful one, but I think that Anthony was probably going to show, and that Adrien already said it, is if you have that DMAA that is so much increased, like in that Marfan, that young lady, that you will increase that DMA. And then a lot of people add an Aiken osteotomy to try to correct in the Aiken osteotomy. And then you end up with sometimes a very stiff joint and a tendency to the Hallux Valgus with an incongruent joint that is painful. So I think you need to combine some techniques, and that is a little bit the message of my talk. And it needs to be reproducible.
And what is post-op protocol with the scarves that have no hardware?
Just walking next day with a special shoe for 4 weeks. It's auto-stable. It's more stable because it's like from the carpenters. You just push them down again, and they're stable, and you're already. When I take the joint and I'd like to do like this, it's stable. I cannot take them out of each other again.
And so week 4, when they're back in their regular shoe, do you let them do all impact activities, or do you restrict their activities?
They walk according to the pain.
Okay.
And at 4 weeks they walk with a normal shoe, but they are always had the advice to be calm and not to think they are big sportmen and they can do whatever they would like, because we all need 6 to 8 weeks to end up with a fusion of those bones, those fragments. It's a normal protocol like we used to do with the screw. But the screw is not giving you a stable osteotomy. it's stabilizing the things, but this is stable from itself by the impaction. I invite you to read the paper.
But I think you need to keep them a little calm the first 2 months, and then tell them to be aware that they cannot stand on their tiptoes and things like that, and that they cannot do city trips, because sometimes you have patients coming back at 1 month having done a city trip. So then you might end up with some secondary displacement, which is not a problem, but I think in the first 6 weeks, it's important to keep them a little bit calm. That's my experience.
Can I ask you a
For
question?
all of you, in the US, MIS is very new, right? I mean, it's very young, very new. In Europe, you guys are much more advanced than we are. What would you recommend as the stepwise approach to getting to MIS scarf, right? I mean, that's much more advanced than Mika. And even in the Mika here in the US, there's still many people who aren't even doing it. So what's the learning curve, and how did you guys get to where you are now?
Well, I think, yeah, sorry, Eduard.
No, I will never recommend to start with the first ray. I recommend to start on the lesser rays, on the fifth ray, which is a perfect indication for MIS, and also toes. Because at last, the first ray maybe is, as we were talking previously, that the difference in between a good surgery in the first ray and in a good surgery open or MIS is not very big. At last, it's the same. But where I think that you can find the real advantages of MIS in the lesser toes, fifth toe, and lesser rays. But never start by the first ray. Sorry, Adrien.
We only have 1 minute, 45 seconds left. So maybe it's time to say as a conclusion that Hallux Valgus treatment has a lot of tools, and that I think the key message is to use the proper tool and know how to use it and when to use it. And I think this is the key message. I would like to thank everybody, the panelists, for being here. I would like to thank Selene, Parekh, the foundation, and the sponsors. Thank you very much for giving us the opportunity to share those cases with you.
Laurent, thank you so much for moderation. And Anthony, I'm sorry that the guys couldn't get your presentation to work. But all of you, thank you for your input and your insight. We'll be back in a few moments.
Thank you.